Welcome to Introduction to Cardiovascular A&P and Conduction. This is part 2 of course 1 with Cardio Learning Solutions, and let's get into it. Our arteries are dynamic in themselves and their structure, and they vary from veins. For the sake of this course, our arterial structure that we really want to look at as a foundational concept is the layers of the coronary. The arterial structure is composed of the tunica intima, the tunica media, and the tunica externa. The arteries branch into arterioles and then into capillaries that are dumped into the venules that join together to form the cardiac veins, which we'll discuss in a second, and those drain into the coronary sinus. Go through the whole system again. The difference between veins and arteries is veins do not have an elastic membrane, but rather valves to bring the blood back to the heart. And our arteries, being a higher pressure system, they need the elastic membrane to handle the systemic pressure and the contractile force of the heart. So let's take a look at the right atrium. This is the first structure of the heart that receives the deoxygenated blood back from the veins from all over the body. And so your right atrium is a lower pressure system. The venous side is lower pressure in comparison to the arterial side under normal circumstances. So if we look at this diagram, we see that the SVC and the IVC bring blood back to the heart from the body. The SVC in particular brings the blood back from the body from the portions of the vasculature that are above the diaphragm. And the IVC brings blood back from everywhere else below the diaphragm. And then we discussed our coronary sinus is the structure that brings blood back from the coronaries once it has gone through the myocardium, through the coronary artery itself, and it is then brought back to the right atria via its own circulatory system. Other structures in the right atria that we need to bookmark or know about, we have the SA node that is located near the SVC and the AV node that is located near the coronary sinus. So the SA node is the body's personal pacemaker that beats between 60 and 100 beats per minute. And our AV node is that portion of the tissue that slows that conduction down for just a short period of time through the atria so that it can allow for ventricular filling, and then it hits the His bundle and contracts. So we'll talk about that a little more in depth, but that's your basic structures to the right atria. It's also important to note the fossa ovalis. This is the closure of the foramen ovale. We see this open in patients that have congenital heart defects, and so they might even have an atrial septal defect that would shunt blood from the right to left atria. So in the cardiac cath lab, specifically, we do ASD and PFO closures to normalize that system because it is a system of pressures and gradients, and it's very dynamic. So we don't want that mixing of oxygenated and deoxygenated blood. So the coronary sinus, I think, is as intriguing as the sinus valsalva. It has such an important function, yet we don't really dive into it and talk about it a whole lot, but they're very important components in the cardiac cath lab specifically. So as discussed, that coronary sinus is the venous blood return to the heart. And looking at the cardiac circulatory pattern itself, we think blood to the heart, to the lungs for oxygenation, then to the heart tissue, parallel to it going out to the rest of the body, and then back to the heart to be transported to be oxygenated. So that's your very cyclic process there. And if we just look at the myocardium itself and taking that process, this venous structure is the part of the heart that transports the blood from the coronaries to be oxygenated. So it starts in the right atrium, and it is a conduit of that blood routing from the coronaries back to the right atria. Looking at the coronary sinus deeper, and we take a cross-section of this, we see it in the right atria, and it wraps all the way around the left atria. This is that conduit of blood from the ostium, the proximal portion, starting in the right atria, wrapping all around the left atria. It has several different vessels, the MCV, the lateral veins, and the anterior ventricular veins that all coordinate with our coronaries to bring blood back to the heart. Kind of interesting, I'm not going to lie. We know it wraps around the left atria, and this is a structure that facilitates our BIV leads in device implantation for cardiac resynchronization therapy or CRT therapy. So let's say you're in the cath lab and a patient needs a BIV device. Where's that third lead going to be placed? It's going to be placed in the coronary sinus. If you're in the ICU and you know your patient has a BIV device, this is where that lead is placed. But also within that procedural setting, we can use this structure for electrogram mapping regarding conduction for EP procedures using a CS catheter, or a catheter that is placed in the coronary sinus that wraps around the atria and allows us to see different impulses coming through the heart at different times, and it's a lot of fun stuff. Let's dive into the left atrium. As you see in this cross section, it is a very interesting structure. And looking at this structure as a whole, we see that there is a windsock-like structure that is known as the left atrial appendage. And while there's no discernible use for it, it presents specific issues with patients with AFib for thrombus formation. Within that left atria, we have the 4 structures known as the pulmonary veins. These are actually a right and left pulmonary vein that are made up of superior and inferior structures. There's typically 4, but sometimes there can be a variation of that. Knowledge application time. We have a patient presenting to the facility with a DVT, or a deep vein thrombosis, and is having a procedure within the cath lab. What is the vessel that would transport the thrombus to the right atrium? This is kind of a trick question, and it's something that if you are asking yourself what vessel, you first have to determine where the DVT is. Is it above or below the diaphragm? And what is the risk for the patient if left untreated? So pulmonary embolism, we know that the right atria, blood goes from the right atria through the tricuspid valve into the right ventricle and through the pulmonary valve into the lungs. And so if this thrombus was located above the diaphragm or in our upper extremities, it would come from the SVC. And if it was your normal lower extremity DVT, it would come from the IVC. And this brings us to what procedure could the patient be having to mitigate this risk? And this is an IVC filter placement. SVC filter placement is pretty rare. I can't say that I've ever placed a filter in the SVC. It's predominantly in the IVC. A lot of times we will place an infusion catheter to lyse the clot if it's located in the upper extremity. So really interesting thing there that kind of gets you thinking. Moving forward, we can start to talk about our valve characteristics. And looking at this view, we can see how it illustrates a crown. And coronary is derived from the Latin term crown. We see how it wraps around those structures. You see that on the lower portion of this, the coronary sinus, and how it relates to the coronaries. So if you're looking at this superior view of the heart, we can see the AV and semilunar valves. Looking at the valves, we can see that their anatomy is distinctly different. They have different sizes and different distinct characteristics, but the atrioventricular valves are a mitral and tricuspid valve. Again, within the wordage of that atrioventricular, it's the valves between the atria and the ventricles. And then we have our semilunar valves, which are the pulmonary valve and the aortic valve. The atrioventricular valves, first we have the tricuspid. This valve is between the right atrium and the right ventricle. And we have the mitral valve. The tricuspid valve is a 3-leaflet valve, and the mitral valve, which is located between the left atria and the left ventricle, is a bicuspid valve. These two valves, the way I remember it, is right tricuspid, RT. And mitral, I remember LM alphabetically. Left side of the heart, mitral valve. Right tricuspid. So that's one way that I remember it. Starting with the AV valves. And so here's the cross-section of our heart again, and the atrioventricular valve's function is to provide extra support and valve tethering with the chordae tendineae and papillary muscles. So the AV valves on the right and left side of the heart, their function is to withstand full ventricular systolic pressure without regurgitation. And how they do that is through anchoring by the chordae tendineae, which is attached to the papillary muscles. These valves also have a larger orifice because of a lower pressure system as we watch blood flow through the valves. This is during diastole. This is the active filling of the ventricles. Specifically in the right side of the heart, it is a lower pressure, with the right atria having a typical pressure of 5 millimeters of mercury. So looking at this cross section again, we see the aorta and the pulmonary valve, and how blood during contraction shoots through the pulmonary valve located in the right ventricle and the aortic valve located in the left ventricle. And so here during diastole, we see the blood actively flows, but during systole, we have the AV valve closure, which gives us our S1 sound in our heart sounds, and the chordae tendineae almost snap shut so that the cusp of the valve does not allow back blood flow into the ventricles from the atria. Speaking of those semilunar valves, the semilunar valves are the pulmonary valve or the pulmonic valve and the aortic valve. And their function is to open with contraction or systole and close with diastole. The aortic valve is the smallest, thickest valve and withstands the highest pressure. So we're talking the left ventricular pressure to the AO systolic pressure within our systemic system. Typically, the aortic valve has 3 leaflets, 2 having the coronaries as mentioned with the sinus valsalva and 1 without. The sinus valsalva also is a protective means from that pressure from the LV as it's pushed through the aorta, and it decreases the ballooning effect or stretching that can occur. So when we have a bicuspid aortic valve, our patients are at higher risk for ballooning of the aorta. And the cusp of our valve, the way the semilunar valves work, is it prevents backflow during diastole, unlike our atrioventricular valves, which the inlet flow is during diastole and they close during systole. There are the pulmonic valve and the aortic valve right there. The cross section of our heart again, and you see the aortic and pulmonic valves. These are our semilunar valves, and they get their semilunar name from being a lunar style shape. When they are open, we have systole and blood is pushed through them, and when they're closed during diastole, that structure prevents backflow of the blood. This closure of the valve is our S2 in our heart sounds. To round out our discussion, we need to look at the cardiac conduction structures in relation to the anatomy and physiology of our hearts. Looking at this, we see the SA node, the AV node, Bachmann's bundle, the His bundle, left posterior bundle, all the bundles. Looking at the cardiac conduction cycle more in depth, we see it is a very, very interesting dynamic process. In the right atria, we have the SA node and the AV node. Our intrinsic pacemaker, SA node, beats 60 to 100 beats, and our AV or backup pacemaker is 40 to 60 beats. Both are fueled by the RCA, so it gets blood flow from the right coronary artery. The AV node allows for a very slight delay in conduction before it hits the His bundle down through the ventricles, and this delay in conduction allows for the filling of the ventricles. And then we see all the way down through the heart the Purkinje fibers, the bundle branches that create our system of conduction. And this system is illustrated by our EKG, our PQRST. This represents a single heartbeat going through the SA node by the P wave with our QRS and the contraction all the way through the Purkinje fibers and then back up to start another conduction cycle. This is every single beat of our heart in a healthy, normal system. that wraps up our very first course. Again, thank you guys for watching. And if you want more, comment down below, subscribe to stay in tune with everything that's going on, and I will see you guys in the next one.